Hi, my name is Andrea Lee Johnston Green, and it is my honor to present to you my applied research project on implementing patient-reported outcomes in the collegiate setting. While we look at the importance of patient-reported outcomes truly in any clinical setting, it is vital that we start with some background on whole patient healthcare. Whole patient healthcare is simply defined as addressing the disability from both a function and structure standpoint, as well as looking at possible restrictions of both activity and participation that our patient may have incurred as a result of their injury or condition. This concept of whole patient healthcare has truly been encouraged over the last decade as an attempt to provide more ethical and efficient treatment of individuals as a mean to bridge the gap that we often see in our healthcare delivery systems. The ultimate treatment goal for any patient should be not only simply complete recovery from an injury or overcoming a condition, but truly the improvement of their health-related quality of life. And this is where the importance of patient-reported outcomes come in any clinical setting. Patient-reported outcomes, also known as PROs, can be a critical tool or link in improving communication between patient and clinician while enhancing the perspective of whole patient healthcare and patient-centered care. Now, what are patient-reported outcomes or PROs? Well, patient-reported outcomes may be generic or they may be regional or condition specific in nature. A generic patient-reported outcome can be used with any injury or condition to assess overall well-being. Some examples of generic PROs include the short form 36 and 12, as well as the PEDS QOL. On the other hand, there are regional or condition-specific PROs. These include the LEFS, the Lower Extremity Functional Scale, the DASH, the disability, the arm, shoulder, and hand, and the KOOS, the knee injury and osteoarthritis outcome score, among many others. As noted by the names of these instruments, they are geared or designed for regional or condition specific kind of injuries or illnesses. So we again have those generic PROs and we have the regional or condition specific PROs. Some clinicians may simply choose to use a generic PRO that they're comfortable with and use it with all their patients. Some may use a more regional or condition specific PRO. Some may use a combo. Some may do both the generic as well as the regional or condition specific with their patients. But like with any tool that is developed that we wish to implement in our clinical setting, there's always going to be barriers. Clinicians may say that barriers for using of the PRO include not being educated on patient-reported outcomes, not knowing how to score patient-reported outcomes, or interpret patient-reported outcomes and then implement those results into their clinical practice. If you were to ask the patient, a patient may say some barriers include not knowing the purpose or understanding the purpose of the PRO, or there might be a health literacy barrier where the patient doesn't understand or comprehend what that particular PRO is trying to ask. But if you were to ask both the patient and the clinician for probably their top barrier, it would be time. And with the use of PROs, what we're looking at is the patient needs to have time to complete the PRO. And again, the clinician needs to take the time to properly score and interpret those results so that they can apply their new knowledge into their clinical practice. So we've discussed a little bit on whole patient care, a little bit on patient-reported outcomes. Let me give you a setting. Texas State University, large university in Central Texas with a diverse and large amount of undergraduate and graduate programs. Home to one of the state's oldest athletic training programs, it is seeing this program currently transition between a bachelor's degree and an entry-level or professional master's program. On the clinical side, there are currently 6 full-time athletic trainers working with approximately 500 student athletes in 14 Division I athletic teams. These full-time clinical ATs are supported by numerous graduate assistant athletic trainers, the students in the athletic training program, as well as 9 full-time faculty members. But here's where the concern lies. The present musculoskeletal evaluation process employed by this clinical staff, while generally comprehensive, does not include patient-reported outcomes other than a numeric rating scale for pain. So you could hypothesize that the athletic trainers in the system prioritize a clinician-based data for their patient exams versus patient-based data. This could lead to a barrier in whole patient healthcare. When applying the information we know to our fishbone diagram, we see the concepts of people, policy, process, and culture. Our people. Some of the older staff simply just were not educated in the efficient use of PROs. Some of the younger staff are educated, but do not wish to put in the extra effort to use them. The students are learning about PROs in class, but do not see them truly implemented in the clinical setting. And there are athletes that have not been educated about how vital patient-reported outcomes are in improving their treatment process. The culture. Again, 6 full-time ATs with numerous athletes on numerous teams. Time is definitely going to be perceived as a minimum to accomplish all their tasks they're already assigned. And with 4 athletic training clinics on campus, there's a lack of cohesiveness in the evaluation process. So looking at current policy in the process, we see here there's no true patient-reported outcome policy. There's no educational meetings for the staff on the use and importance of the patient-reported outcomes. No set manner to store the PROs, and no designated time during treatment to complete them. Again, with the NRS basically being the only PRO that is used in a typical evaluation of treatment, thus the problem that PROs are currently not being used in this particular setting. So the idea was, let's initiate a quality improvement strategy. How are we going to do this? Where are we going to do it? So an efficient manner of delivery was implemented as part of this rollout strategy for ways to include patient-reported outcomes into the patient evaluation with this initiative. Patients evaluated at the University Events Center Athletic Training Room who sustained an injury resulting in a minimum of 1 day loss of physical activity participated. This facility was selected as it serves the majority of the teams on campus and is the home to 4 full-time clinical staff. These patients that met the time loss requirement completed the disablement of the physically active PRO upon initial evaluation of the UEC ATR. To avoid any potential for technological failure, such as a tablet malfunction, loss of internet, the DPA was completed on pen and paper, and then the completed DPA was stored in a secure location. The DPA was once again completed at the beginning of treatment sessions on the designated biweekly follow-up times as well as upon discharge. This DPA, the disablement of the physically active, was selected because it is a generic PRO. This generic PRO once again can be used with any injury or illness or condition. So any athlete that presented to the UEC ATR that met that time loss qualification, regardless of the location of their injury or their condition, were qualified to complete the DPA. As you see here, this DPA is relatively simple to understand, which helps us meet or kind of conquer that health literacy barrier that may potentially exist for some of our patients. Almost every question on here has some examples to kind of further explain what is meant by that question. And we see different domains addressed. Those 16 questions on this PRO address the domains of functional limitations, disability, impairments, and quality of life. So it's very encompassing of every aspect of this patient's health. We look at motion, stability, maintaining positions, overall fitness, and their well-being. So it gives us more, from a clinical perspective, a really true key of assessing where they are, not just from our measurements with the goniometer or MMT, but truly their perspective. We employed a PDSA cycle as part of this initiative to make sure everything was covered. The plan was to educate each AT on how to use the DPA with the patients that are evaluated in this particular athletic training room. All the patients with a time loss injury were going to complete the DPA as part of the do. So we planned it out, how we're going to educate them, what's our plan to go ahead. The patients that have the time loss injury are going to complete the DPA, and then we're going to compare how many patients suffered a time loss injury during the cycle versus how many suffered a time loss injury and completed the DPA. And then ACT. The goal was 80% completion. So we hoped that from all the patients that had sustained a time loss injury evaluated at the UEC-ATR, that 80% of them would complete the DPA. If that goal was not met, then the action would be to implement a new goal or strategy. If that goal is met, then let's look at perhaps a new patient-reported outcome that we could employ, or maybe make a more challenging goal. And this is what we found. Success was achieved for completion of DPA upon the initial evaluation, as is evidenced here in Table 1. If you look, during the time of this Quality Improvement Initiative, 21 athletes were evaluated for acute injury in the University Event Center Athletic Training Room. 7 were deemed eligible for the DPA, and of those 7 completed it for a 100% pro-completion rate upon initial evaluation. However, if you turn your attention to Table 2, you will notice that we fell short on completion for follow-up DPA. An individual that was eligible to complete 2 weeks after initial eval completed the form, 1 for 1. That was 100%. However, we had 7 athletes that returned to participation before that 2 weeks mark was up. Of those 7, only 4 completed the follow-up assessment for a 57% score or completion rate. So that shows an area for improvement to occur. Looking at the individual assessment scores, we can see them on Table 3. 4 patients that completed the follow-up DPA showed progress in mental health aspects as well as overall health scores. 1 patient did report a worsening in physical scores between initial and second assessments, and overall there was a 12.5 point improvement in overall DPA scores. So you could look at this worsening here in the red circles, went from a 5 to a 6. Not necessarily clinically significant, but did see a worsening in physical scores, but saw their mental scores increase, so their overall score increase. So we can see here that comparison and see that we can track for improvement or notice some particular worsening of symptoms. So our lessons and limitations from this QI initiative. Some things we noted: the relocation of the ATR that is located at the UEC and a restructuring graduate assistant schedules during implementation of this quality improvement initiative led to some communication gaps. Those communication gaps were potentially the reason why the follow-up DPA did not occur quite the way it should. So we do know that better tracking of follow-up DPA administration is needed. It was noted on calendars, it was noted on forums. There could be a better way to follow up with that. The athletic training students were not utilized as much as they could have, which that could have improved the team aspect of this QI plan. They perhaps could have been more responsible in helping to remind the clinical staff, full-time as well as graduate assistants, that a follow-up DPA was needed or was required or was due on a particular patient. However, we did also note that patients and clinicians alike reported ease with the use of the DPA, especially in terms of time, and then on the patient perspective with health literacy. Patients all reported that they felt that the DPA in particular was easy to understand. The questions were straightforward, and if they did have a question, their clinical staff member was able to explain it to them. And then there was also great support from both the athletic training leadership on the clinical side as well. This came from the Director of Sports Medicine as well as the Associate Athletic Trainer, who are both still clinically practicing individuals. And their great support led to a second small initiative or PDSA cycle occurring during this larger one. The second PDSA cycle actually was brought about with the staff at the End Zone Athletic Training Room. They decided to continue within this initial cycle, but they adjusted the due. The due was adjusted to using electronic version of DPA using email delivery system. They thought that they could be more effective, and they could definitely meet the 80% goal, if not higher, on follow-ups if by using electronic mail delivery system. However, this very short cycle revealed that 20% completion rate for the 5 patients that sustained a time loss injury of a day or greater. With this cycle did not go long enough to do the follow-up DPAs, but for the initial evaluation, there was only a 20% completion rate. The one individual that completed the form did so via pen and paper, as the UEC patients did. The remainder, the other 4 patients that qualified, were sent the emails and they did not complete the forms. So, in conclusion, there are still many barriers within a clinical setting, but with planning and a step-by-step approach, successful implementation of PROS may be achieved. With minimal time taken away from treatment, a generic patient-reported instrument that could be completed in a few minutes made both the patient and clinician comfortable with the acquisition of this data. It's also important to note that this form could be not just pen and paper in the clinic, but also on a tablet in the clinic as well, but needs to be handed directly to the patient. And the success is also defined by the ability of this clinical staff to use the PRO with patients as described, while also planning ahead, implementing another cycle of collection, and then also now currently looking at other ways and other PROs that could be involved. I thank you for your time, and I definitely want to thank my Texas State AT faculty and staff for bearing with me during this quality improvement initiative. Thank you.